So we shall now go on to our next speaker, Dr. Shantha, who's a senior consultant in the Department of GLAUCOMA at Shankar Nethralaya, Chennai. And she's going to be telling us on managing tube exposures, her pulse.
Good evening, and thank you for inviting me to participate in today's meeting. The topic is management of cornea-related complications following tube surgeries. This is a serious complication following the use of glaucoma drainage devices. The rate of endothelial failure has been reported to be as high as 17% to 35%. Rate of tube corneal touch varies from 5% to 23%, and corneal graft failure 8% to as high as 46% following the use of drainage devices. There are multiple mechanisms involved, which include postoperative shallow anterior chamber, peripheral anterior syncytial formation with progressive AC shallowing, tube corneal touch, turbulence at the tip of the tube, tubes placed anterior to Schwalbe's line, and intraocular inflammation. The risk factors for endothelial cell loss have been studied. This is a prospective evaluation of 59 eyes which underwent power-belt implantation. The tube was placed in the anterior chamber in 45 eyes and the pars plana in 14 eyes. Endothelial cell loss in the anterior chamber group was 13.1% at 1 year. There was no cell loss in the pars plana group. The tube corneal angle was negatively correlated with corneal endothelial cell loss. Tube corneal touch may be an issue with intermittent touch with eyelid movement. This was reported in the Asian Journal of Ophthalmology by Dr. Bhaskaran from our institution. You can see the close opposition of the tube with the surface of the cornea. This is a serial visualization of the AGV using ASOCT done in 48 eyes of 48 patients. Serial scans were done from the first post-op date to 12 months. Tube length and angulation from the iris and corneal side were measured. The tube shortened and had a tendency to move towards the cornea. There was an increased tendency in post-uveitic and post-PK eyes. There are multiple ways that we can reduce the risk of tube corneal touch. Limit the length of the tube in the AC. Place as close to the iris surface as possible. Increase the bevel at the cut end to avoid plugging by iris tissue. Avoid areas of PAS. Position in the ciliary sulcus or pars plana, and position through an iris hole. This was a patient with extensive PAS, was an epiphytic eye. So here we positioned the tube through the iris. However, the bevel was short and iris plugged the opening, causing elevated IOP. With iridoplasty, this block was removed and the tube became functional again. Repositioning may be necessary, and this can be done through the pars plicator or the pars plana. This was a report on repositioning through the pars plana done in 9 eyes of 8 patients. The indications were progressive anterior chamber shallowing and corneal decompensation, tube corneal erosion. Vision remained stable or improved in 7 eyes, and IOP remained under control in all eyes. One patient had a retinal detachment 9 months later, which was successfully repaired. So pars plana placement requires a good vitrectomy, and once the tube is implanted, the end of the tube has to be carefully visualized, and any vitreous which is entering the tube has to be cut in order to prevent blockage. This is the pars plana insertion of the tube. The entry is made about 3 millimeters posterior to the limbus. The needle is inserted, 23 gauge, and then the tube is inserted so that it goes behind the plane of the iris and can be visualized. The rest of the procedure remains the same. This is a patient who had corneal endothelial touch, as seen here, with the tube very close to the posterior surface of the cornea. Following reposition close to the surface of the iris, you can see that there's a considerable distance from the cornea. This was again a patient with very close to corneal positioning of the end of the tube. So repositioning here was done through an iris hole. So you can see here that this is well away from the surface of the cornea. Transcameral suture to prevent tube corneal touch was reported. This was done using 10-0 polypropylene double-arm sutures with straight needles. So this was done limbus to limbus, and the tube was positioned away from the surface of the cornea. It remained in place for a 20-month follow-up, but produced significant astigmatism. The approaches for trimming excessive length of the tube include externalizing the tube through an overlying corneal section and trimming it, or stabilizing the tube intracamerally using a 30-gauge needle and excising a portion using micro scissors. This is how we most often do it. We use an end gripping, which is forceps, hold the end of the tube and then cut the tube with the scissors. Remove the fragment through the paracentesis incision. Sometimes the length of the tube is not sufficient for repositioning, so we may have to use a tube extender. So this is a procedure showing how we use the tube extender. The tube is exposed right up to the edge of the plate. It is trimmed. The extender is connected to the distal portion of the tube. It is anchored to the surface of the sclera using nylon sutures. Following this, the tube is trimmed to a sufficient length and then introduced through the needle track as close to the iris surface as possible. This was a report on GTT malpositioning with tube corneal touch in 22 eyes of over 300 patients over a 10-year period. And these are the associated features for corneal decompensation, which include pseudoficibulous keratopathy, uveitis, multiple procedures, and angle closure. So in conclusion, patient counseling about the possibility of a second procedure, place the tube as close to the iris surface as possible, use a shorter tube length, plan for appropriate location, place in the serial sulcus or pars plana in aphakic and pseudophakic eyes, look for excessive tube movement, and timely intervention to prevent corneal decompensation. Thank you.
Thank you very much, Dr. Shantha. That was a very thorough talk. Murli, would you like to take some question?
Yeah, I have a question, madam, for eye syndrome, especially Chandler's and progressive iris atrophy. What is your initial procedure of choice if they land up with glaucoma? I mean, would you do a trabeculectomy or a pars plana tube? Many of these patients have clear lenses, and the corneal endothelial count is like around 500 to 900. So what would be your initial procedure of choice? Would it be a pars plana tube or would it be a trabeculectomy?
We do perform a trabeculectomy if the anterior chamber is fairly well formed and we don't have peripheral anterior synechiae at the superior limbus. And that works fairly well. But the problem is that the primary pathology is in the endothelium and it can grow over the stoma and over a period of time reduce filtration. So in case there are extensive peripheral anterior synechiae everywhere and it's not possible to create a trabeculectomy stoma, then we do go ahead with the tube implant. We place the tube in the sulcus. If it's a phakic eye, if you're able to make an iris hole and then introduce the tube through the hole onto the surface of the iris, that would be better. So these are the techniques that we use when there's eye syndrome.
Thank you very much. I paused your time, Murli. We have to move on.